And then we kept on getting requests over and over and over again for Afghan providers or people who could speak the language or gender specific providers or and myself, my colleagues have given multiple lectures on cultural competency and how to deal with Afghan patients. And that is great if your organization institution is doing, but then, what about beyond that? And I think that the limitations of regarding, especially when things kind of became much more difficult to deal with after folks were relocated from the bases to their new homes, to their new cities across the country. And this relocation process was pretty interesting. Pretty much all of the major cities across the US had a certain amount of budget and they could accept a certain number of Afghans. So all these, some people say 130, some people say 89,000 Afghans were literally randomly and in some ways assigned to go to a new place, a new city, and start their new life. And what we have to remember is that the Afghan culture is highly dependent on community and support from the community. So you're isolating these people in places like Iowa and Idaho and Nebraska and folks that are so dependent on their community, not really having any community support. So that's one. And then second, the folks who are there, who are welcoming them, are very genuine and want to help and want to have them be part of this new American society. However, they don't know how to do it. I think the intention comes from a great place, but then the impact may not be exactly what they want. And we're having to deal with a 14-year-old boy who hanged himself in his high school, because of the bullying and lack of mental health care support. And this is not just one, case, or a young man with newly diagnosed psychosis walking around with access to weapons and somewhere in Colorado. These are the kinds of phone calls that we would get saying, how can you assist? How can you help in these situations? And sitting more and more in these meetings, myself and our colleagues, we noticed a significant need for mental health care. And during this time, we sat down and we started talking about how can we come up with a system that is going to be able to address basically what is the highest level of need. And for us, it was mental health. Because if we can make sure that folks are healthy and their families are healthy, and then that will then enable healthy integration to society and success long-term for these individuals. And knowing that the culture is going to basically lead to suppression and alternative ways of dealing, and healthy ways of dealing with it, and that we wanted to kind of stop that generational trauma. And I don't know if we can, but at least that's the intention. If we're not doing it, we have women who are isolated at home with multiple children without any support in community. And there's no extended family either, because in Afghanistan, they're dependent on extended family to help with childcare. But now this person is now stuck at home. They can't even go outside because they have multiple children. Their husband is working outside. They're doing the best that they can, but they have also a significant trauma. And then they can't say anything outside the house when they are dealing with difficulties. So they go home and they have culturally acceptable ways of unleashing their trauma and frustration that usually results in domestic violence. So now these children are living in an environment that's completely unsafe and regarding their nurturing and obviously bonding with their parents, and this continues on. And they may become successful and the kind of economic sense eventually after a generation or two, but at the cost of what? And then what happens to these kids that they're growing up? And specifically, I'm looking at the young teenagers, prepubescent, and what happens in the situations where they end up living in these really impoverished areas, and how do they integrate into society, and what happens to these kids, and risk of things like radicalization. So we can go and take this mental health crisis from the individual aspect and what's happening with each person and take it beyond and apply it to what's going to happen to the population as a whole. And to me, as an Afghan American, that was the basic thing that kept me up at night, is the adults, I care about them, but it's the children and, the trauma and how it's going to impact them. And then what it means to the Afghan population and the identity as a whole, I felt responsible to be able to do something. For us, when we came, we didn't have these resources. A lot of refugees didn't have the resources that refugees have now, which is great. But at the same time, things are so scattered and uncoordinated that a lot of people are doing the same work in silos, and then there's a lot of waste resources. So basically, coming back to the idea of the mental health, what happens here in mental health care and with Americans? Most of us don't have the luxury of paying $120 an hour to see a therapist once a month, or how frequently you need it. Most of us rely on our primary care doctor to maybe talk to us for a little bit and maybe give us some kind of a pill that helps to regulate our whatever chemical imbalance we have. And maybe through that, we then are able to see some therapy as well and have some other resources that we can seek out. So the average American, forget the refugee, is dependent on their mental health care through primary care. And that's the model that we're going to work with. We're going to work with access to primary care for these refugees that's going to be culturally competent, that's going to basically take into account language barrier and gender specific. And then with that, we're going to then be able to identify those people who are going to need more intensive treatment and care, be able to provide therapy, whether we start with group therapy because people are so resistant to individual therapy. And then you are then creating a dynamic of continuation of care and trust, and hopefully people opening up and eventually realizing that this is beneficial and maybe they want to do individual therapy. So this is basically the idea. So what we did was that we also wanted to have access nationally, because again, not everywhere is Northern Virginia, not everywhere is Texas, not everywhere is California or New York, tri-state area where the population of Afghans is higher. We wanted to make sure that we were accessible to anybody across the states. So telehealth was the way to go. But again, like Dr. Mubashir mentioned, technologic access is an issue if we're going to be talking about the most vulnerable of the population, and specifically the women at home. So we wanted to make sure that we had a way to guide these patients through their care. And this is where the idea of the patient navigator came in. So we have a telehealth system and a patient navigator system. Our telehealth system can have any provider of any background. We can have anyone who's licensed. Licensing restrictions is another one. So if you have somebody in a state and the only provider that can see them that has the language and the cultural competency is another state, but their license is restricting them for doing a telehealth visit to the other state, what's the point? But what you could do is if you have a provider in one state and they have a primary care doctor in their state, the primary care doctor now needs consultation with a psychiatrist. There's another psychiatrist in another state who can speak the language of the background. You can do a peer-to-peer consultation, and that is covered through the licensing, because then you can have a psychiatrist in another state who will then attend the visit with your primary care doctor at the same time. So we basically are looking at existing resources instead of creating new resources, because we don't have the luxury of millions of dollars to create new things. And also, we're a very small nonprofit and nobody knows us and nobody wants to give us money because we've never done anything of this scale before. But what we do have is that we're subject matter experts. Not only have we experienced it, we're physicians, we're going through taking care of patients, but we're also Afghan and we know what our people need. So basically just started writing, researching and with the models of telehealth projects before, and coming up with what existing laws are and what the system is to begin with. So we have our triad of the primary care health person who can do peer-to-peer with whatever specialist they need. We're going to focus on mental health care, but we're not going to come with mental health to the patient. So we're going to open up the door by saying, you can see a provider for anything you like. It's free. And guess what? We're also going to do a screening questionnaire regarding depression, anxiety, trauma before we have you start seeing the provider. And then with each month, we're going to continue to do these questionnaires, and we're going to follow you and see if you're going to continue to need the services. And after 3 months, you may not need them anymore. You could just see your regular doctor, or you may continue to stay in the program. And the entire process is basically you're followed, each patient is followed by a patient navigator who's of the same gender, who is can speak your language, and is a physician from Afghanistan. So because we are Afghan Medical Professionals Association, and most of our work was catered around basically assisting providers, medical providers from our Afghan background to come together, do educational stuff, do health fairs, occasionally help people in Afghanistan. We also had people who came to us and said, hey, I just came to the country, how can I get back into medicine? So we had a lot of people who had that, and they were driving Ubers or delivering pizzas, and I mean, super highly qualified people doing work that was, way overqualified for. And now we have them, they're not licensed physicians here in the US, but they have significant experience and knowledge, and they're doing great work, and they're still working in healthcare. So we have people who are really looking in, have a stake in what they're doing, and they know that they can make a difference, and they've gone through the same exact thing. So currently we have 7 physicians who are patient navigators. We started with USCRI. It's a grant through ORR, Office of Refugee Resettlement, through the State Department, and it's called the HEAL Project. And our telehealth platform is through a small physician-run organization called Heal Health. And their basic idea is access. And their basic idea, they've existed prior to HEAL Project, but Heal Health idea was to improve access for healthcare by basically going beyond insurance. So you pay a monthly fee per patient, and you have access to a physician. And if you want more access, you pay a higher fee, but it's as minimum as $50 a month. So that's it. I mean, so what you're responsible for is basically your medications and whatever else. And if we have people who can't pay, our patient navigators go and find resources that can cover the cost of these things for much cheaper, or places that things are less expensive. So we have a wraparound service where we're able to then, have the patient basically handhold from the beginning, from the time that they're referred to us for whatever mental health reason. And we have different levels of how quickly we need to respond, with red being most serious. Obviously, we don't deal with people who are actively suicidal or actively using drugs, or, will need to be required with any kind of law enforcement. We want them to be out of that immense acute danger. But beyond that, we basically take care of everybody. And we're then able to enroll them, have them with the patient, the provider sees them with the patient navigator, and the provider gives instructions of what needs to be done. The patient navigator then follows up with the patient and makes sure that they fill their prescriptions, take their medicine. There's follow-up phone calls, and then there's another appointment. There's a minimum of at least 1 appointment per month for 3 visits, and then beyond that as needed. So that's basically, what our model is. It's a new model in terms of how underserved population, specifically refugee population, is being treated from a mental health point of view. And just since starting in March, we just bypassed our 118th, I just saw, patient registry. So our goal is to serve over 2,000 patients. And so we'll see what happens. I'm sure we're going to be there. But this is basically, the story of what we are doing at HEAL or with AMBA. And, hopefully this can be something that can be applied to a lot of other populations, not just refugees. So this is definitely something that can be replicated. So thank you.
Questions?
This is really quick. Do you remember how much the charge was for the emergency room?